Good morning and welcome to how I manage my day as an ICU nurse. So this is a nursing video. I haven't done a nursing specific video in a while. I know they've been all NPs yet, but first rule is make sure you grab the right badge. I always put mine on in the car because I want to make sure I have the right one for work, and I hate getting to the front door of the hospital and not have my badge. So anyway, let's go. All right, it's gonna be a good day. And if it's not, oh well. Alright, let's get to this portion of the video. Sorry I'm not in the hospital or in that kind of setting, but I can't film there, so I will do the best I can and keep this interesting. So first off, I get to work, get my Starbucks, get report. I love to do bedside report. I know this is what you should do, and a lot of nurses don't like doing this because they don't want to wake the patient. It's just easier to talk at the computer and have everything. But what I like to do, and why I like to do bedside report, is even if like a nurse is still busy getting other patient or giving other report for like their other patient, I like to go in the room and kind of just skim over what I'm gonna write down on my brain. This is my brain. I showed it to you at the beginning of the video. If you saw my how I manage my day as an NP, I use the exact same brain, but I just kind of go over, like, I list my drips, I look at the monitor and the vital signs machine, I see what they're currently in, what their temperature is, I look at the vent settings real quickly and just jot them down. If I happen to be able to see the ET tube and the OG tube, like what that is at, see what's hanging, is there tube feeding, what kind, what drips are currently running, looking, seeing if I have a Foley. So I kind of just get a gist of the patient. This is briefly before I actually start getting report if that other nurse is busy. I like bedside report also because it catches errors or like infiltrated IVs. I one time had a nurse who tried to tell me, this was like when I was on step down, that my amiodarone had infiltrated and that's why the patient's heart rate was not controlled. And I was like, no, we traced the line like together at bedside report, so I know this was not true. So like I've had things caught during this time, or just things that saved my butt. So I personally love bedside report. It is a little awkward when you're talking about a patient in front of them, but anyway, let's move on. So after I get report, the first thing that I like to do is go and introduce myself to my patients. So if they're on a vent, I just kind of briefly walk in the room, make sure the pet alarm is on, even though I know they're not going to go anywhere. And then make sure my name, fill out my whiteboard. Perfect time for admin to get off my butt is to fill out my whiteboard. And if the patient is awake and alert, I introduce myself and say, hi, I'm Christina. I will be your nurse today. Give me 5 to 10 minutes to kind of review everything. And I'll come back and let you know what our schedule is for today. I'm sorry if you guys have seen my videos in the past and a lot of this is repetitive. It's just a lot of things have not changed for me. I kind of have this flow that I've had for years, and I kind of like to work it and keep the same flow. But basically, I don't like to go into a patient's room without knowing everything about that patient. Reason why is because I've learned and felt like patients' families will lose confidence in you so quickly if they ask you a question and you don't know the answer right then and there. And obviously they don't know that you just got to work and that you've barely seen them. Like, it drives me bonkers when patients' family members call at 8 a.m. and they're like, I want to know how the patient's doing, like, how are they today? And it's like, I just got here, I don't even know them yet. Like, give me a minute, you know, let me settle and like get to know them. I'll have a better plan. Like, we just got here. But anyway, they don't know our workflow, so do the best you can. Okay, so I use my NP brain and my ICU brain, the same exact brain, but in different ways. I also am resource nurse sometimes, and at my job, resource nurses do a lot of audits. We audit the ventilators, the central lines, we audit drips and stuff like that. So a lot of my audit stuff is on here, so it just helps me get the best information that I need for my patient. So I personally, after getting a report, I like to look at my labs first and kind of see if the labs match the picture I was given. I also always take what the night nurse or the previous nurse says with a grain of salt, because I've had several instances where like nurses will tell me like, oh, if a patient's family or the patient is very difficult, and I think it just boils down to how you approach a situation. Obviously, if they're telling you that they're going to be difficult, you can go in with a different mindset, but I always take what that nurse says with a grain of salt, and I also like make sure to read the chart myself, because you never know when someone else is going to miss something. So I like to review all my labs. I like to see the trends. I go over everything. So CBC, chem panel or CMP, the electrolytes, coags. I always have had this like investigative mindset. I wanted to be a police officer before being a nurse. So like, I just like to put 2 and 2 together. That's just how my brain works. And so I like to review all my labs and see what picture am I gathering, and does the picture match the diagnosis that I was given. I next like to review the meds. While I review the meds, I am crossing off things in each section. So like neuro, what is the pain? What is my sedation? Cardiovascular, do I have any blood pressure parameters? Do I have any blood pressure medications? Respiratory, am I on any type of medications for breathing? And do I have breathing treatments? Anything like that? GI, do I have my PPI? Am I on Protonics? Am I on Pepsid? If they're on a vent, I need to make sure that they have these. If they're on fentanyl, I need to make sure I have a bowel regimen. If not, now I know how to ask my doctor. Foley, are we taking it out? Do I have something like Flomax or doxazocin if we need something? And then DVT prophylaxis is huge for me as a trauma NP, so I always make sure to see if we have SCGs. Do we have heparin or Lovenox? And then what antibiotics are they on, and are those antibiotics appropriate for what I'm treating? And so then that's how I use my NP brain combined with like my bedside. After I look at the medications, I make sure that everything makes sense. What are my PRNs? Do I have any drips? What drips are they? And after that, I like to review all my scans. So even though it is not my job as a bedside nurse to look at my scans, I like to review my scans. If my patient is intubated and on a vent, I like to quickly just open the chest x-ray and see, is my OG tube below the diaphragm? Is it in the right spot? Am I going to be able to push medication and make sure that it hasn't moved? Because usually the morning chest x-ray was only done a couple hours before I got there. And so I like to look at my scans. This is also the perfect time for me as an NP to kind of get better at reading scans. So I'll read what the radiologist said about this, and then I'll try to personally go through the CAT scans, whether it's head, chest, abdomen, pelvis, and try to read it myself and see if I could correlate it just as practice. But I do like to read all my scans and see what is going on, because what if I have some really black pleural effusions or something, and maybe my patient needs Lasix, or what if they're gonna need a thoracentesis that day? So I just like to be very thorough as much as I can to do what's best for this patient. After that, I read the doctor's notes. What is the plan for the day? What is the HMP? Is there anything on the HMP history-wise that was missed, or was that's not in our SBAR? What is on the home med rec? Are the patients on their home meds? And so after I get a picture of what I am gonna do for the patient for that day, I write down a schedule. Writing down a schedule for me has helped me. I like to give it to this patient. If you've heard this story a million times, I'm sorry, but one time as a new grad, I was on PCU with my preceptor, and one day I didn't have a schedule. I wrote it down. I like writing my meds down. The reason why I write my meds down, even though you don't have to, and because the Omnicell or Pyxis, whatever you have, will tell you what meds are due, or so is your computer. I've noticed that when I don't write my meds down, sometimes I'll go to the Pyxis, and sometimes if they get new meds, Omnicell, it won't let me take it out until 15 minutes prior to the first dose, which is so annoying to me. So instead of that, I just like writing down. I hate not being efficient. I'm very good at time management, and I hate not being efficient, and I hate having to go back for things. So I just found it best to write down. So I have a whole like section that's literally like what to do that day. So I write down my own time frames of what meds I'm going to give when, what labs I'm going to draw when. And that way, when I go to the Omnicell at these times, I don't forget something. Or if something's not in the Omnicell and it's like in the patient's bin or like is coming from pharmacy, I just have a clear picture. I don't want to go back and forth a million times. So when I was a new grad, I had this patient who complained that I was never in the room. She never saw me. And then the next day, I made sure to go in there hourly, and then she complained that I was in there too often. So I was like, how can I fix this? One day you're complaining I'm never here, and one day you're complaining I'm here too much. So the way I fix this is, if my patient is awake and alert, I will tell them the schedule. Nobody likes to wait in the hospital. Nobody likes to feel like they don't like what's going on, especially if they're NPO and they're hangry. And then with family, I find that if I tell them, hey, I'm gonna give meds at this, and this time, I'm gonna turn every 2 hours, we're gonna do this, I feel like it kind of eases their mind, and I gain like a rapport with them so that they trust me and they know I'm gonna be here and like checking on their family. So I just like giving them this schedule. I also learned from being an NP, now that I'm a provider and I do bedside, now I learned that if I want something for my patient, which is another topic that I want to discuss, I am not the type of nurse that's gonna just go to work, do my orders, and go home. I'm not a professional pill passer. I am there to advocate for a patient, and especially in the ICU, you have to do what's best for your patient. You're the one fighting for them. You're the one speaking for them. So if you see something that they need, I want to bring it to the attention of my doctor. So if that's the case, when I'm reviewing my medication and my labs, and I notice like, okay, my magnesium's low or my potassium's low, like I need replacements for that. And now that I'm a provider, I know how much replacement I need. As I was becoming a new nurse, I realized that, especially night shift, like you get scared and intimidated to call doctors. So instead of calling doctors and being like, hey, I need this, and they're upset or they don't want to talk to you, I learned that some doctors, if I say, hey, patient has nausea, may I have Zofran, and like Q6 hours or something, like, I don't know, just kind of throw out there what I want, what I need. I feel like they were more like, okay, put it in, you know, opposed to like, hey, patient's throwing up, what do you want me to do? And then they have to sit there and think about it. I don't know, just giving them a suggestion, I feel like made things a lot more smoother for me at night to call. So now when I am overviewing everything, I'll know like, okay, if my potassium's 3.4, I need at least 20 to 40 MEQs of potassium for the day. Does my patient have a central line? Does my patient have peripherals? Are they able to eat? Do they have an OG tube? Like, what type of potassium do I want? So I'll just jot down like, okay, 40 KCl IV, whatever. So that's just an example. I will mark down what I need. That way, when I have this list, or like, let's say I see there's no bowel regimen, or hey, my patient's not on Pepsid, or hey, they don't have labs for tomorrow or something, I'll just jot it down. That way, when the doctor rounds, I don't have to make any extra phone calls. If I need something, I will make sure that in this one moment when we are rounding together, when they came in to see this patient, this is the perfect opportunity for me to say like, hey, I need this, this, and this. Can I have this, this, and this? What are your thoughts on this? These are my concerns, or like, can we do this for the patient today? This is the perfect time for me to reduce calls to the provider. As an NP now, I know what it's like to get phone call after phone call after phone call. And especially when you get the stupid phone calls. And I used to, you know, not really sympathize as much with the doctors when they would get mad at the nurses or like yell at them, or like, you know, not be so nice on the phone when you call for things. But I've really learned and have experienced my own situations with stupid phone calls. So I just try to avoid them. And this helps me do that for my patient. Next, I'm going to talk about how I actually go about my day. So I look at all my labs, medications and stuff, and I try to do that by 8. However, I talk a lot and I love my coworkers and my job, so I spend a lot of time like chit-chatting in the morning, walking around, hey, how are you? And like, I just want to do my job. So I try to get this done, say hello to everyone, by 8 o'clock. And then I'll kind of make an overview and look at both my patients and I'll see. I know in nursing school they tell you to go see your sickest patient first. I don't fully believe that. I want to look and see, especially if I know the person, like, are they on a vent? Are they very sick? Are they very stable? Are they very chatty? Are they very needy? Like, do they have a lot of meds? Do they have some meds? Like, what is going on in this room to make my day flow faster, more efficient, and easier? So if a patient is on a ventilator and they are going to take a majority of my time, and I have somebody who is a walkie-talkie in the ICU who, you know, probably doesn't have as many medications, then it makes more sense to me to go pop my head in, make sure all my drips in my vented room are full or, you know, sufficient, see if my patient's vitals are stable, but I'll go see the other patient first, because if I'm just handing some Pepsid, some metoprolol, PO real quick, and can get my quick assessment done and like talk to this person, then it makes more sense for me to go see this person real quick, just give them their 2 meds, and then go spend time in majority of my time in my vented patient's room. However, if you have a vent and a walkie-talkie, and this walkie-talkie is like very needy, very chatty, very like fluff my pillow, massage my back, like do this, this, and that, even if they only have 2 meds, I'm not gonna go see that person first. I'm gonna go be in my vented room where I know I have a majority of things, where the person is not gonna take a lot of my time because I have more things to do with them. They are my more critical patient, but I can get these things done quickly because nobody's asking me to fluff their pillow and rub their back. So I think you just kind of have to weigh what is gonna be quicker and more efficient and stability. Not too long ago, I had a patient who was on a vent and a patient who was stable. So I thought, and I walk into the room, I introduce myself, and 7:15, all hell breaks loose. And anything that could be done to a patient got done to this patient. I'm talking about lines, intubation, CAT scans, operating rooms, like all this stuff. So that person that I thought was stable turned out not to be. And that is another thing that I have to consider, and why time management to me is so important. So I chart in my rooms as much as I can. My 8 o'clocks, I definitely chart in my room. This gives me a chance to establish a rapport with my patient or the family. This allows me to do my assessment and my charting at the bedside. I know a lot of people complain about charting, but I chart as I go. I make sure that my charting is up to date, especially vitals. Every hour, when I was a new grad, or when I was a new ICU nurse, they hounded me in my head that your vitals should be charted within no later than 5 to 10 minutes after the hour. So things that I make sure I'm documenting every single hour are my IV spreadsheet, my I's and O's, and my vital signs. If you're not doing that every hour and you're not doing that charting consistently and you're waiting hours later, something is wrong with you. You need to reevaluate yourself, because you need to make sure these patients are critical. You have to make sure that you are documenting this, because how are you not, if you see that the trend is trending down or getting worse, whatever, if it's the heart rate or the blood pressure, and you're not paying attention and you're documenting these things hours later, what have you been doing? You're failing your patient. Every vital sign can be like dictated in a way that is important or not. But let me tell you, I was taught by my professor in nursing school, you need to know your patient, and the ICU is the perfect place to get to know your patient very, very well. An example of this is I had a patient who the whole day, the heart rate was 80 to 90. Normal, right? Yes. GI bleeder, But then I noticed like 2 hours before the shift, the heart rate was like 100 or 110. Still normal, not out of the ordinary. Like 110 is a little tacky, but still normal, right? But not normal for this patient. And the temperature starts going up. My temp's been like 98 all day. Now it's 100 and something. Like, this is something that I notice because I'm documenting it every hour. I'm noticing this trend because I'm making sure that I'm doing this. And if I'm waiting till the 4 hours later to document, you're not gonna notice that trend right away. It's gonna take you 4 hours if you're even paying attention to what you're documenting. So I make sure that those 3 things are always documented, especially my INOs. If I'm gonna have a Foley in a patient, then I'm gonna make sure that I'm paying attention to this urine output. What is the trend on the urine output? Is it going up? Is it going down? Why is this important? Am I becoming oliguric? Am I showing signs of diabetes insipidus? Like, these are things that are very important to me as an ICU nurse. I was always taught, if you lose your kidney, you lose your patient. So those are just things that I like to focus on. I also want to make sure that my charting is up to date because I never know when my patient's gonna crash. And you never know when your coworkers' patients are gonna crash. And I'm the type of nurse, a nurse told me this when I was a nursing student in ICU. He told me there are 2 types of nurses, one that gets coffee, when shit hits the fan, one that stays, and one that gets coffee. Both nurses are important, but what type of nurse do you want to be? And I was like, he goes, we need coffee. That coffee nurse is important, but what nurse do you want to be? And I was like, I love the action. Like, I'm in the ICU for a reason. Like, I want to be that nurse that when shit hits the fan, I'm there. CPR is one of my favorite things to do. So you best believe as soon as I heard the like code blue alarm going off, I'm the first one in the room hopping on that patient doing the compressions. So I want to make sure that if someone else's patient is crashing, I'm going to be able to step away real quick, help this nurse out, and not have to worry like, oh my god, I have a million meds to give or a million things to chart. So I just make sure that my charting is always up to date. Other things that I have to make sure I have time for or scheduled is, am I going to go to MRI? Am I going to go to CAT scan? Do we have to put in art line? Do we have to put in central lines? Are we intubating today? Are we doing thoracentesis, paracentesis? Like, is there EGD scheduled? Are we going to OR? What are we doing? You never know in the ICU. Everything can be so predictable. Sometimes I do all these things at once, and sometimes I don't do any in a day. But because it's so unpredictable and you just never know what's going to happen, I want to make sure that I have time frames for everything and that I manage my time well. I personally am not the type of person that likes to pass the buck. I want to make sure that everything that needs to get done for my patient gets done that day. I don't want to pass anything to the night shift. They have enough on their plate, and it is very much harder to do things for patients at night or like on the weekends when like not as many people are at the hospital. So I want to make sure that if I can get a scan done or if I can get a procedure done, that it gets done that day. So by organizing and managing my time efficiently, or like coordinating with CAT scan, like if I need a CAT scan but it is getting too close to the end of the shift and then shift change happens and then it gets delayed, like no, I don't want any of that BS. If my patient needs a scan and it is going to change a treatment, then I need to get this done. Now that we're kind of done, I'll go over my brain with you real quick. So whether you're an ICU nurse or not, this is kind of tailored. Obviously, we all work in different specialties. So the type of ICU that I work in is not specialized in any sense. It is very generalized. So what that means is I don't want to call it a MICU because we do everything. I work in a very small community hospital and we do trauma, open hearts, strokes, heart attacks, neuro. We're a level 2 trauma center. I don't know if I said that. So we have one ICU and we kind of all do everything. If you're open heart trained or not, that's different. We're getting CRRT soon, which I'm very excited for. So I know a lot about a little. So I don't know a little bit about a lot, but I know a lot about, or I don't know a lot about one specialty. I know a little bit about a lot of specialties because you just never know what we're gonna get. So that's why if you look at my brain, it is very tailored to kind of like a mixture of things because like if I work in a cardiothoracic unit, I'm obviously gonna have different things on here. If I worked in a neuro, I'd probably have like EVD measurements and pop-offs and stuff like that on this, but this is just a very general brain for me because I do a lot of different things. Okay, so neuro, I have my GCS or my A&O because both of my jobs do something different. My trauma job, my NP job, we go through GCS, and at my job we do A&O. I have my Q hour, how many hours, like neuro checks every hour, every 4, whatever, I write it down. I write my pupils here, my left and my right, and then here I just circle if I have restraints and then what time they're due. Sedation, very important, what type of sedation I'm off. And then P is for pain. So I have fentanyl, lidocaine, Dilaudid, Tylenol, gabapentin, Robaxin, Oxys, 5s, and 10s. So this is more tailored to my NP job because we use multimodal pain control. At my job, we usually, my nursing job, just do fentanyl and then like some morphine. C and F, that's whether they're C-spine precaution, full spine precaution. And then here, this is the cardiac, so their blood pressure, their rhythm, their maps, whether I have goals greater than 60 to 65 or like 140, 180, whatever, 160, just depends on the patient. And then what is their ejection fraction if they have an echo, what kind of meds are they on, and then lines I have here, so either they have vas cath, where their IVs are, central, A-line, peripheral, or if they have like an IBC filter in case we can't give like DVT prophylaxis. Moving down to respiratory, this is like just the oxygen, if what's their respiratory rate, their SpO2, if they have an incentive spirometer, ABGs, are they so often, when is it due, the ET tube size, centimeters, teeth and lip. I cannot stand going off lip. I go off teeth because teeth don't move, lips swell, but that's a case-by-case basis. Ventilator, what's the settings, whether it's AC, PC, pressure support, whatever, pressure control. But basically the rate, the tidal volume, the PEEP, the FiO2. If they're on BiPAP, what's the IPAP versus the EPAP, and then the FiO2. High flow nasal cannula, the flow versus the FiO2. Then if they have a chest tube on the right or the left, what's the milliliters output of each? And then here I just write whether it's a suction or water seal. I usually put my patient's label here, the diagnosis, the history, and then like put the labs. All right, so next we're gonna go down to GI. So for GI, whether they're MPO, what kind of diet they're on, if they have the OG tube, NG tube, or CoreTrack. So CoreTrack we have at my MP job. I don't have this at my nursing job. Whether it's in the left nair, the right nair, their bowel regimen, Senna, Docalax, Marilax, Colace, PPI, whether they're on Protenex or Pepcid, Zofran or Compazine, anything for vomiting, tube feeding, how many milliliters, what type of visit, if I have flushes, how often, and how much am I flushing. FlexiSeal, I'm very big about FlexiSeals, especially in GI surgery, general surgery. I want to know when it was put in because you shouldn't have it more than 30 days. GU, what are the ins, what are the outs, what is my total, my plus, my minus, Foley catheter, whether I have PureWick, PrimaFit, urinal, and uric, if I have dialysis, like how many liters out, what days, FEN is fluid electrolytes, so what IV fluids, what electrolytes were replaced, or like do I need replacement, heme, daily labs, Q12, Q8, Q6, duplex, like if they had a DT ultrasound, when it was done, is really big at my MP job, especially in the ICU because we do day 1, 3, and 10. Heparin or Lopinox, what's the dosing? This is more for my NP because I have to make sure they're on the right dose. Blood, if they got any, then antibiotics. So this is vancomycin, Flagyl, and either whatever cephalosporins they're on. When we started, very big at my NP job. I don't really pay attention to the dates at my nursing job. And then Tmax, what's their Tmax for the day? Endocrine, if they have an A1C, how often the how often are the ACT checks, if I have insulin sliding scale, if I have Lantus, and then musculoskeletal, whether I have PT, OT, or SLP. SLP I just put here because in my NP job, we use a lot of SLP, and since it's a therapy, I just put it in here. Skin, if I have any skin issues. And then, okay, so this little man, I work trauma, so that is why I have this little guy. I just like to circle where my injuries are. And then this is more for my NP stuff because if I have consults,
and they need a follow-up, I write it down here. And then disposition, like where they're getting discharged to or anything like that, I write here. And then here is my kind of what I'm running. So if I have sedation, Prevent, Precedex, Versed, whatever, put that here. IV fluids, what type, if they're on pressors, and then anything miscellaneous. So that is just kind of a general idea of what I do in a day, or how I manage my day, how I go about my day, how I organize and structure my day. So I hope you found this video helpful. If you guys have any questions, leave them down below, and I'll see you on the next video.